Good afternoon, everybody. I hope, post-lunch, raining outside, feeling a little sleepy. I only don't intend singing a lullaby to put you all on to sleep. What I'll be speaking is completely clinical. This is essentially to bridge the gap between the reports given and what is the clinician thinking, so that we can come into a common understanding, and that even on the other side, the people who are reporting also should know what we are looking at and how much we rely on this, and what's the importance of giving value and how much it matters to us in a day-to-day clinical practice. Couple of years back, AMH was once considered whether should we not do, isn't just an FSH and a scan enough to do in cases of female fertility. But that's not the thing anymore. Currently, in reproductive medicine, AMH is like the molecule of the moment. Many things revolve around AMH. Little bit is known that, high AMH means PCO. Now, how high is resistant PCO? How high is treatable PCO? But there are many, many things. So perhaps, a little bit of understanding on that could be useful for all of us. I don't know much on standardization and all those. Mine is only a clinical field. So I would give in whatever my inputs are on these, and please do feel free to ask wherever it is necessary. Yeah, like I told you, this is like just to introduce about the AMH. It was discovered way back by Alfred Jost, and it has been serving as a very potent biomarker of ovarian reserve since 2002. So it's a peptide. We all know that it is primarily expressed in the females as well as in the males. It is both. Always we think that, AMH means its utility is only in the female. Not really. It starts its utility even in the males. If you have some, empty testes, like nothing is there. So there to even to differentiate between the disorders of sexual development, there also AMH has its own utility. So in the males, it is synthesized by the Sertoli cells of the testis since the 5th week of embryonic development and then during the whole life. In females, from the 36th week of gestation. During the female life, until menopause, it is expressed in the granulosa cells of small and growing follicles. But it is not expressed in those which are already sensitively acting to the effect of FSH. So the hormone passes in the blood and its level can be measured. Okay. So like I told you, it helps in individualization in treatment strategies. In males, it is in 4 stages: fetal, early postnatal, childhood, puberty, and early adulthood. I have already told you where and how it is synthesized. So testosterone is responsible for the differentiation. FSH, through its receptors on the membrane of the Sertoli cell, stimulates AMH expression. Serum levels of AMH are relatively high in this stage. That is the fetal stage and early postnatal stage, which is comparable with the levels in childhood. In childhood also, there is the same trend. It continues. Just before the boy attains puberty, there's a small dip, and then it remains constant throughout life. Only in cases of delayed puberty, not developing any secondary sexual characters and all, even in the boys, AMH can be done. It has its own clinical utility. So in the adulthood, as a result of stimulatory effect and the prevailing inhibitory effect of the testosterone, it is just maintained at a static level of around 6 to 7. So in females, it has varied applications, much more than what we can think of it is just utilized in. So there are the lower levels of AMH are also seen to be a very good marker of congenital central hypogonadism. Low AMH are typical for precocious puberty, and persistingly high AMH also indicates that there can be a physiological delay in the puberty. Because even in the females, just like the males, there's going to be a small dip in the level of AMH just before she attains her secondary sexual characters. But there's no specific correlation like before telarchy or before adrenarchy, nothing of that sort. Just before about 1.2 years before she starts with her period, there is a small dip. So in the female, it is produced only in the granulosa cells, and AMH levels, it's almost stable throughout childhood and adolescence. The peak is seen probably at 25 years of age, and thereon it just goes on reducing and until it is almost not detectable to 0.03 or so at the time of menopause. There can be a modest late prepubertal peak and a slight decline, like I already explained. And FSH also plays a role in AMH regulation. As the sensitivity of the follicles go on increasing, and as the follicles start getting recruited for the reproductive career, that is when you see that the AMH goes on reducing, and there is an inverse correlation. Invariably, a low AMH is always associated with a high FSH, except for one case which I would like to mention here. Many a times we see like AMH of something like 4 and 5, and FSH will be 15 to 20. And on scan also, I have seen that there are good number of follicles. Only this category fits into the case of FSH polymorphism. Currently, the treatment strategy for FSH polymorphism is to treat with a combination of FSH and LH on a long protocol for IVF. And we have had successful cases of pregnancies for that. That can be the only exception. Otherwise, it's always inversely correlated. So like I told you, this is where we have seen that in all these, there is an FSH, there is AMH which is expressed, and this AMH actually prevents this being taken up by the FSH. It's being more conservative. It's trying to protect them from getting recruited. Therefore, that is reflected in blood values at any point of time as to how much more time does a woman have to procreate or to conceive. And once the FSH action starts, though it is still there and it is produced, which is evidenced by recovery of AMH, even in the follicular fluid when we have done IVF, but it has no major role at that time. It does have some other clinical utility, but nothing to do with the growth of the follicle. And that is not the one which is reflected in the blood either. So these are the normal ranges of AMH, which you all must be knowing better than me. And the peak of AMH is at 24 and a half years, after which it starts declining. So as a marker of ovarian reserve, it is always correlated with the number of follicles that we see on scan. Mostly. Invariably, there is a very good correlation. People with good number of follicles, like about 10 to 15 or on each ovary, they have always AMH of more than 2. Even in the latest automated generation 2 assays also, 2.5, 3, these ranges. When we come down to about a combined value of say about 10 to 12, that is like time is ticking. They need to start acting faster. That's when we see ranges of between 1 to 2. Or 1.5 to 2.5, depending on the assays that are used. And when it is very less, like, something like a total of maybe 6 or 8, that time it is at 1 or slightly less than 1. So based on that, from the point of an infertility specialist's view, we decide the treatment based on what is the level of AMH. And currently in today's, medico-legal so many challenges and all that, the patient can actually sue us that you knew it very well, you should have told us. So it is like in any reproductive center, any reproductive medicine unit, it's almost like the first investigation to be done, because then we can explain about how much more time do they have on hand to plan their treatment as far as the female fertility is concerned, of course with a lot of other things. So AMH has greater specificity and sensitivity as a marker than determination alone with the FSH and other steroid hormones. Female fertility, even the other important hormones are FSH, LH, inhibin B. Compared to all of them put together, it's only the AMH and the age of a woman which have independent predictable value in terms of live birth rate. So the ultimate success of any treatment in infertility is finally we come down to the live birth rate, not just a happening of a cycle. So there, these two find its utmost importance. It is independent of the phase of the cycle. Do we have a role in precocious puberty? Yes, because usually you see a dip in AMH level just before puberty. It's supposed to be up to 7 or so till the girl is about 12 to 14 years. If we see values of lower than 5 and already the child has some sort of secondary sexual characters, then I think the parents need to get alerted that probably the child is having an earlier tendency and they could take whatever care that has to be taken, meet the endocrinologist and things like that. So as a marker of early ovarian cessation also, there are many cases of labeled unexplained infertility. Actually, unexplained infertility is a very weird term, and if it goes up to the depth of evaluation, probably one or the other causes would be found out. And up to 30% of the candidates of unexplained infertility do have some amount of ovarian insufficiency. So that's very important. So therefore, there also we have to see this. So POF, that is premature ovarian failure, occurs in 1 in 100 women before 40 and 1 in 1,000 before 30. So does it have a role as well in prediction of menopause? Yes, it does have. Okay. So here we can see, I will give you the values. Values of, it is assumed that AMH values of less than 1 and lower may translate into an ovarian reserve, and usually it's about another 10 to 13 years once they touch a value of 1 or a little less than 1 that they have the time up to menopause. So an AMH of less than 0.2 nanogram per ml occurred on an average 5.9 years prior to menopause in women aged 45 to 48 years and 9.9 years in women aged 35 to 39. However, if it was more than 1.5, here you can see it is 6.23 years in this age group and 13 years in this particular age group. There are some women, who have a couple of psychological issues as well, and they're very paranoid. Even if they're fully all right, they just want to know, oh, when am I attaining menopause? I'm feeling hot, I'm feeling that, I'm feeling this. Couple of things. I mean, each patient is different, and we need to address everybody's needs. So if there is one such a situation, well, this test can help it. AMH and PCOS, it is like a husband and wife story. While the husband can stand tall and supportive in all other ways, at home it can be a Tom and Jerry show. So while it actually screws up the, intrafollicular environment, but still, I would rather say a higher AMH is more promising to give a result than a lower AMH. At least the numbers are there. There are so many eggs. We can work out one or the other way to make that woman pregnant. But if the AMH is very low, then that is the real problem. So it does serve as an additional marker in the diagnosis of polycystic ovarian syndrome. And increased production of AMH induces decrease in the sensitivity to FSH. I'll just show it to you in the diagrammatic way. See what happens here in PCOS, that first the major culprit is hyperinsulinemia. On account of hyperinsulinemia, you have increased androgen, LH, other growth factors. There could be some genetic or epigenetic factors as well. All in turn result in elevated AMH. Now, what does this AMH do? It decreases the sensitivity of the follicle to FSH and also decreased aromatase expression. Decreased aromatase expression again increases the androgens, and also it reduces the estrogen level. It's not uncommon to see in PCOS, they go on taking injection after injection, while you expect that a dominant follicle, which has crossed about 14 millimeter size, should have at least estrogen of 150 picogram. But it is not uncommon to see in PCOS, you'll have 3-4 follicles month after month, and they don't conceive. And one fine day, if you try to test the estrogen before giving the HCG trigger injection for ovulation, we have found that the estrogen would be about 50 or 60. Then we know that there is no good egg. If the main ingredient is not good, then how will the pregnancy happen? The success rate is as good as the egg. So that's also a very important counseling tool as to why people with repeated ovulation induction and yet they fail. Though PCO is not an indication for an IVF, it is because of these reasons, in these subtle things that happen inside, that they spoil the intrafollicular milieu, that ultimately it requires for us to pick up the eggs, see under visualization under the microscope, select the best, and then do the pregnancy with an ART cycle. It's the same thing that I have given in the pictorial manner. This insulin and LH, androgen, multiple small follicles, it helps in a lot of recruitment, but they don't grow beyond 8 millimeter. The androgens and all that will make the follicle grow only up to a level of 8 millimeter, or many a times up to 10, and they get arrested. How much ever injections we give, whatever we give. Those are the cases where we have to test the LH and probably give them a course of a HRT or an oral contraceptive pill to reduce that LH concentrations. Even metformin has a beneficial role. AMH and reduces FSH action. The same thing. Again, because of there is no ovulation, there is low progesterone, on account of which the pulsatility of LH is very high whenever there is no progesterone. Yeah, why I say that perhaps in PCO, it is the AMH which has the highest role in prediction that yes, this is a PCO. How are they going to behave is because of this. See, the ultrasound is a very, very helpful marker. This is the whole pool of the ovarian follicle, like you have the pre-ovulatory, the antral, early antral, pre-antral, and these are all the primordial, primary, secondary follicles. The ultrasound can pick up only from this, that is the antral follicle and the pre-ovulatory follicles. But the AMH can pick up even the early antral follicles. Therefore, it has a higher role in picking up the PCO patients. And there are many critics who have actually said that is the Rotterdam consensus really efficient? Does it require a revision? There have been some suggestions that inclusion of AMH of more than 5 nanogram has to be taken. But it is not yet, totally proven, because the number of subjects studied in that particular case study was only about 224, and it was not a randomized control or anything of that sort. So AMH is not regulated by gonadotrophins and acts as an autocrine or paracrine rather than a systemic factor, and thus is not a part of these negative feedback drop involving gonadotrophins. These are the same things which I have already told. Like I told, the resulting low levels of estrogen may contribute to the failure of follicle selection. So in PCO treatment, now at what level of AMH do we call it as PCOS? Even among the automated AMH assays also, there is no uniform consensus. One says 1 to 3, the other one goes up to 4, little higher, little lower. We know that only that the first generation, second generation, there's a difference of approximately 40%. It is lesser. But over and above, usually any value of AMH that is more than 3 goes in favor of PCO. But only the AMH alone cannot decide that this is PCO, because as per the definition of Rotterdam consensus, there has to be some either ultrasound or clinical or biochemical signs of hyperandrogenism, and also the history of all the menstrual cycle of non-ovulatory cycles, any 2 of the 3. But however, if there is an AMH value of 3, then there should be more than 3. There should be a strong suspicion of PCO based on other clinical factors. They say the range is 18 to 60 picomole. But definitely to call it bang on, it is PCO without any other test, it has to be 35 picomole, not the nanogram. I'm talking about the picomoles. 18 to 60 is the range. This was a big SART analysis involving more than 10,000 subjects. There, the range which they found is 18 was the lowest and 60 was the highest. But only on the basis of AMH, if you have to call it, then it is 35 picomole. And the conversion is obviously 7.14 divided by 7.14. So therefore, at 5 nanogram, yes, definitely it is PCO. But the range between 3 to 5 also, they are known to hyper respond with any kind of treatment, and so the clinician requires caution. And perhaps even the pathologist also, or whoever the person reporting, has to understand that this case needs to be looked into with some other things. It also helps in prediction of hyper response to gonadotrophins and prevention of OHSs. As far as the treatment part in PCOS is concerned, once you get an AMH value of more than 3.4, there is a very, very high incidence of CC resistance. No matter how much of tablets we give, 50, 100 or 150, that woman will not ovulate because of this AMH. And that another very, big time advocated treatment for PCO, for regularization of menstrual cycle, is laparoscopic ovarian drilling, which is thought to reduce the intra-ovarian androgens, correct the milieu, though it is temporary, lasting for a maximum of 9 to 12 months and not beyond that. But still it is supposed to. But if we have a value of more than 7.7, then laparoscopic ovarian drilling is not the treatment of choice, and directly it has to be gonadotrophins. Obviously, one needs to be counseled, the patient needs to be counseled that there can be hyper response, and if at all she lands up into OHSs. Even for the prevention of OHSs, today IVF is a treatment, because you kind of aspirate all the eggs, and as soon as all the cumulus is aspirated, the estrogen will come down. And so there is no OHSs. Even the VEGF, everything comes down, and we actually prevent the OHSs from happening. So, yeah, this is the same thing. This is the article that I quoted. Again, huge number of subjects have been studied in this, and this says that at 7.7, yeah, this is the thing, okay? Yeah, and when, this is the same thing again. if, the third consensus on PCO, which is called as the Amsterdam Consensus, they said that, there's a lot of other things that one has to concentrate on PCO, not just about fertility, from starting to adolescence and up to menopause and beyond. So there is this metabolic syndrome and all that, but AMH has no role in predicting any of the metabolic issues of a PCO person. So the diagnosis of PCO, this was after, heavily critiquing the Rotterdam Consensus, could be, one fine day we may come at this, that either of these also, we just call them as AFC is antral follicle count and the AMH is more than 5 nanogram per ml. With this, we can still confidently call it as PCO. As a tumor marker too, it has shown something. It is for those which are originating from the granulosa cells. And with regards to natural conception, we can't give any correlation on the basis of AMH, because people as low as 0.2 also can conceive and as high as 10 also can conceive. We can only say that the time for conception is okay. As long as they are more than 1.2, with all other parameters being normal, it is worth still trying naturally for at least 3 to 4 months. In ART, it has a whole bunch of uses. So there have been a lot of conflicting data on this as well, that does it have an independent role in the prediction of live birth following an IVF program, that is an ART. Initially in 2011 it said yes, and another thing in 14 it said doubtful, but the current thing in 18 it says yes it is, but not a very strongly associated one. As long as there is even the age comes as the first independent marker, along with AMH of more than 2.2 is highly predictive of a live birth rate in a ART cycle. Okay. And the basal levels of AMH hormone associated with oocyte quality, here also there is a very interesting observation that is made, that for AMH groups where the values of less than 1.6 and those where it is more than 4.5, there were a lot of oocyte problems, inherent problems of the oocyte. Nothing to do with the fertilization rate or anything, but if the oocyte is bad, the pregnancy is also not going to be great. So that optimal good range is in between that, even in an ART cycle. So this is something that I have told that is based on the analysis of 85,062 fresh and thawed cycles. This is a SART data. It almost involved every study that was done up to 2013. There they says, yes, it is a predictor as long as it is more than 2.3. And it, as a very good predictor of cumulative live birth, that's probably because very high AMH, you have more number of attempts with one cycle. And eventually in 2 or 3 cycles, perhaps the pregnancy has been achieved. So the female age and serum anti-Mullerian hormone, these and the relation with that of blastocyst. Here again, the magical number of AMH is 2.6. When it is 2.6 or more, the probability of having a euploid blastocyst as in something that is genetically very normal, could be higher. It is shown to be significantly higher, but the numbers are too small. It's nothing like a big number study. It's about 214 subjects. So it is also independently related to miscarriage rates after IVF and ET. This is more to do with the fresh embryo transfers and not the frozen cycles. Perhaps here it is also the levels of estrogen which are playing the role for missed abortions and things like that. They said values of less than 1 and values of more than 7 are associated with a higher miscarriage rate. Follicular fluid AMH. This is another very interesting study. They said that the follicular fluid should have traces of AMH or AMH of less than 2. Those where the AMH in the follicular fluid was more than 2 was invariably associated with some sort of chromosomal abnormalities in the embryo when a PGS was performed, commonly trisomies. And in third-party reproduction as well, in today's age and time when people are like, first I have to study and then I have to get married after I find the partner of my choice, then I'll build a house, then I'll do everything. So by the time you come to think of a baby, for many people it's almost 40 plus. So they're invariably, if there is no choice left, they need to go for a donor program. Even while selecting a donor, if there is to be a single test to be done apart from the scan as well, it is an AMH. An AMH of 2.6 certainly gives a very good cumulative pregnancy rate even in a donor IVF cycle. So effect of obesity, it is seen that in obese PCO, the levels are lesser by 25%. So that clinical correlation has to be perhaps kept in mind. And there is an impact of these bariatric surgery as well as these keto diets and various crash diets that one does for weight loss. It's not uncommon, in fertility centers, they say that first you lose some 10, 12 kilos and then come. Yes, she will lose that and come. But in that, if my AMH becomes less than 1, I really had it. So one has to really think about it before we advise those drastic diets and bariatric surgeries and all that. In interest of the patient, first an AMH has to be done only if it is well above 3.3, then only they can go for that if they are planning for fertility in the near future. Even in these chronic kidney diseases on hemolysis and after kidney transplant as well, these people also have a utility. For those on hemodialysis, AMH has no meaning because it is taken like some uremic toxins and it's always going to be very high. Normally in all these chronic renal diseases, the AMH is about 40% lower. So at least if we are not able to, make them bear the child, there is an option of surrogacy. We need to counsel them and understand what are their future chances and then understand and then do it ahead. And also, like I told, infertility preservation. Someone may perhaps want to freeze their eggs, keep it aside, and after their renal transplant, they can still undergo a pregnancy. In family planning as well, when a person is on oral contraceptive pill for continuously 3 months or so, there is going to be a slight decline in the AMH values. And before advocating any sort of oral contraceptive pills and all that, it is essential to check the AMH value first and then advise them. If there are in the borderline between 1 to 1.5, then it is best not to give them OCP because that also can have a detrimental effect on the AMH. As far as pregnancy and postpartum is concerned, there were some people who said that during pregnancy it has to rise, it has to come down, various things, otherwise it's associated with preterm and all that. But a systematic review has proved that there is no role in either during pregnancy or in the postpartum period. It is known to revert back to its normal levels by about 7th or 8th week after the delivery. So about the AMH assessment, I think I don't have to explain much about that. Among the automated assays, you see that even in these, there are some differences, and even between the temperatures at which they are stored, there are differences even in the same assay, but none of them have attained any sort of a statistical significance. So we can just keep a broad range of, the normal range should be considered anywhere between 1.5 to 4, keeping into mind all the 5 assays. Anything more or less should certainly warrant any further steps to be taken. I won't be talking about all these things and the normal values. That's about it. Thank you very much for a patient hearing. And I thank the organizers for giving me this opportunity to come and give my viewpoint. Thank you. Pre-IVF, yes. All cases we do. Very rarely. Only in, just to differentiate when there is an undescended testis or whatever it is. Yeah, only there. Or if there is absent secondary sexual characters, at age of 14, 15 plus. In those cases, only in the male we do an AMH. Otherwise, it is not done. Yeah.
What's the role of AMH in delayed puberty or delayed menarche? Any role?
It is persistently high. It will be about 10.
In streak ovaries?
In streak ovaries, AMH will be 0. Yeah, that is a total different thing. I mean, there can be constitutional. It is better to do, yeah. If at all it comes to, if there is an AMH value which is on the higher side, as far as the male is concerned, again, that requires a whole series of tests and the line of treatment is different. You'll have to differentiate between, the various sexual disorders of developmental sexual disorders. But as far as the female is concerned, higher the better. At least there is a constitutional delay, maybe underweight, something can be corrected. But if they are low, that is when karyotyping, etc. has to be done. Yeah.
Is there a preference among the gynecologists about the methodology of AMH?
Actually, the place where I work in, that is Milan Fertility Center. In a month, we do, all centers put together, perhaps we do about 150 IVF cycles. Here, we have done AMH for everybody. That's a standard protocol that we have to do AMH, and on that basis only we choose what is the protocol. So we have had our own comparison between what we were using earlier, that is a non-automated assay, and the automated assay that we are using now. The prediction wise of OHS's prediction of PCO as well as poor response is much higher with the automated assays.
Is there any way of increasing AMH? Why I am asking you? I have reported one AMH ratio yesterday, which is less than 1.
No, sir. Unfortunately, no.
Find out, I have treated you and your AMH should be high. So I don't know what way.
That is where I told you, like sometimes there are these subtle polymorphisms. It can be FSH or E2 polymorphism or anything. That is where it plays a role. And for all you know that whatever the antral follicle count may be good, but the pre-antral follicle counts and the primordial pool might be lesser. There can be that occult ovarian insufficiency, which is very, very common in unexplained infertility. So that has to be correlated on a day 2 FSH, LH, E2, scan for antral follicle count, and then see the AMH. There can be some polymorphisms even in AMH, but very, very less. The FSH polymorphism is high. Not necessarily. Any day. Yeah.
I think we should go on to the next. It has been very interesting. Thank you
Thank
so
you.
much.
Thank you so much.
Dr. Meghna.